Welcome, everyone. My name is Gustavo Duque. I'm a geriatrician, Kaufman Chair in Geriatric Medicine at McGill University. And on behalf of the Global Frailty Network and the organizing committee, it's my pleasure to welcome everyone to this symposium, this panel today. This is part of the Frailty seminar series, which was extremely successful last year. And this time this is the second activity from this academic year. So I hope that I'm sure that we are going to have a very nice experience today with our panel of experts in frailty. And before we start and I introduce the panelists, I would like just to mention a couple of things. We're going to have three relatively short lectures, and then we will have plenty of time for questions and answers and for discussion and open discussions amongst the speakers. So please feel free to use the questions, and it's suggested that you only use the questions and answers function. Please try to avoid the chat, but if you have to use it, just feel free. We're going to have all the questions and answer section at the end of the activity. And the other thing I would like to mention is a little bit about the Global Frailty Network. This is an international initiative that just started 2 or 3 months ago and started actually through this seminar series, but now it's a more formal initiative. And all our attendees are invited to join the Frailty Network. Please answer to the survey that is going to be distributed at the end of the session, and that way we will have access to your contact info and we'll be able to invite you to join our network. This is an academic exchange setting open to all academics and researchers and clinicians from any specialty or any type of discipline interested in looking after frailty or researching about frailty in older persons. So with this, I would like to introduce our speakers for today. I will introduce all the speakers to give more time for them to talk. The first speaker is Dr. Simon Conroy, Honorary Professor of Geriatric Medicine in the MRC Lifelong Health and Aging Unit at UCL. He has an extensive experience in terms of frailty with funding of more than 30 million, more than 150 peer-reviewed papers, and he is also involved in the acute frailty network in England and specialized clinical frailty need network and the system-wide frailty network, all in the UK. Our second speaker will be Dr. Josh Kuchel, who is a geriatrician, gerontologist, and professor of medicine at the University of Connecticut Health in Farmington. He holds the Traveler's Chairs in Geriatrics and Gerontology, and also serves as director of the University of Connecticut Center on Aging. He obtained his medical training at McGill, followed by his training in geriatric medicine and gerontology at Harvard University. He has also a postdoctoral research fellowship on epidemiology at Harvard University. He is focused his research on precision gerontology. Effort seeks to discover and test interventions designed to enhance function and independence in older adults, including the field of older adults with frailty. More recently, he is leading the NIA-funded Cloud paper, Older Americans Independence Center at the University of Connecticut. And our third speaker is Dr. Leng, who is a board-certified geriatrician, professor of medicine, molecular microbiology, and immunology at Johns Hopkins University School of Medicine and Blomberg School of Public Health in Baltimore, Maryland. He serves as director of the Johns Hopkins Center on Aging and Immune Remodeling in Baltimore and president of the Milstein Medical Asian American Partnership Foundation in New York. His main areas of interest are frailty, immune remodeling, and particularly immunity against viral infections. in older persons. So with this, I think we all agree that we are very lucky to have our three speakers, and we will start with Dr. Conroy. This will be a very translational type of panel. So our first speaker would be Dr. Conroy with COVID and older people.
Would help if I am muted. Yeah, thanks very much indeed for the kind introduction and the invitation to join such an illustrious panel. I have a very modest and short contribution just to stimulate a little bit of debate, which hopefully we'll be able to pursue as we move through the next 45 minutes to an hour or so. So COVID and older people, I thought it was fading. I hear it's back, the rates are picking up again back in England. So it may not be gone from our memories if it ever does. So I guess some of this is still very relevant today. But the slant I've taken on this is, well, first of all, just to acknowledge, of course, that it's been a massive impact and has changed the way we all live and work. But of course, as I'm sure we're going to focus on this afternoon or this evening, has had a disproportionate impact upon older people who have suffered in relative silence, I would suggest, as the mortality rates in that population were higher than anybody else. We did not hear protests on the streets, certainly not in my country, or clamours and publicity campaigns, apart from a few here and there, which I'll come to in a short while. Which is relevant. This is a population, particularly those living with frailty, who are inherently somewhat reticent, tend not to speak out very much. Maybe that will change with future generations. And I guess maybe you'll disagree, but I think geriatrics as a speciality tends to be, or geriatric medicine in its wider sense, including all other professions working under the umbrella of frailty, tend to be quite humble and nice, easygoing people. We tend not to make too much of a fuss, and I suspect that's part of the problem I'm going to illustrate. So some personal reflections, not so much on the science, but more upon the kind of societal ramifications and impact of COVID and what it means for our futures. So as we've all, I think pretty much every country has been through these lockdowns and radical restructuring of health services. You mentioned in the introduction, I work for something called the Acute Frailty Network, which is a large improvement collaborative based in England that's worked with not every single hospital in the country, but the vast majority of them, trying to support services and reconfiguring their offer to older people living with frailty admitted into acute hospitals. So focusing historically on the first few days of the patient's admission from the time they arrive in the emerge or the ED, all the way through to the first 72 hours when those initial assessments and management plans were implemented. And we spent 7 or 8 years now working with hospitals up and down the country, trying to support them in delivering evidence-based care. Many of them attempted to deliver ACE units, or as we call them over here now, acute frailty units. Others different sort of service configurations, such as liaison geriatrics, supporting emergency departments and acute services more generally. One of the things that we witnessed during lockdown and the restructuring of health services was the rapid dissipation of these services. They just disappeared. They were subsumed. They were turned into hot wards, cold wards, red, green wards, whatever. They seem to have just vanished from people's services, from their hospitals. And yet we didn't see that happening to infectious diseases or intensive care or acute services of any other description. So I just put that to you as an example as to kind of why did that happen? You know, ACE units, really robust intervention, good evidence base behind them, save lives and reduce institutionalization. And we knew or had a pretty much good idea from the outset that COVID was going to affect predominantly older people. So why would any healthcare system restructure or demolish, frankly, those services which stood to have potentially the greatest impact? Remembering, of course, at the beginning of the pandemic, we didn't have any interventions other than those that already existed in the evidence. And then came this voracious efforts across the world to try and understand the disease and develop vaccines and risk prediction algorithms, and there's been a massive amount of work done, and you know, hats off to the scientific community for responding the way it did. But how representative are older people in that? I can tell you from the UK experience, heavily underrepresented. Most of the trials, not all of them, but most of the trials, particularly the vaccine trials, did not include older people living with frailty, especially those with cognitive impairment. And it's not that we can't consent people with dementia. There are processes to recruit people who don't have capacity. So there's no real reason for it. And yet we were already starting to see that COVID was having a massive impact. But we did generate some really fancy drugs and clever discoveries, of which, I'm being slightly flippant, but I recognize the importance of that. But when you put them in contrast to the numbers needed to treat for frailty units or ACE units, have relatively modest impacts. So did we get that right as a society? Did we get that right as healthcare systems about where we put our efforts, energy and resource? But there were some good things. So you may have come across NICE, National Institute for Clinical Health and Care Excellence, which produced some guidance about COVID and used the clinical frailty scale as a risk stratification tool. Was involved in that work. It was a really nice team, intercollegiate team from different specialities, working in a very personal and patient-centered manner. It was good to see frailty being recognised, even though the evidence wasn't quite there at the time, as one of the potentially important determinants of outcomes related to COVID. There's a web link there if you want to have a look at that. And rather late into the pandemic, certainly from the UK, the headline on the side from our on the right-hand side from our Daily Mail, which is one of the Scream tabloids, tends to make outlandish claims, was one of the first to report that confusion could be an important presenting condition for older people living with frailty who got COVID. But that was never in the guidance from the outset. But it was great. It eventually got recognised and brought into clinicians' thinking. But many things didn't go so well. I've touched upon some of them already. The lockdown was disproportionately affected people living in long-term care. I think that's probably a global phenomenon, but interested to see what others' experience has been. And there were long periods where people were locked down in isolation within care homes, unable to see their relatives, dying in care homes, unable to touch or be seen by their loved ones. Very heart-rending stories and very distressing for all involved. That was not humane. There must be a better way. And we also got some things wrong, frankly. So the NICE guidelines that I mentioned early on were misinterpreted at the time of their launch and were kind of being used in all ages and all populations. As I'm sure you're aware, that's not entirely appropriate, particularly those with long-term chronic disabilities in the younger age groups. The frailty paradigm doesn't really hold up so well in those groups. So there was certainly some media coverage around frailty, but it generated conversation and debate, and that in itself isn't a bad thing as we try to advance society's understanding of frailty. So some good things, some lots of good things, some big opportunities that I would suggest we may have passed us by or may have let slip through our grasp. So my question really, and I'd see if this comes up in discussion, is were we ready? A pandemic is a predictable event. It's probably going to happen again soon. It may not be COVID, maybe something else. I'm sure others will know better than me. But are we ready as a frailty community to respond? Do we have the trial protocol set up, the collaboratives, the networks? This network could be one of them. But I don't think we were ready for this COVID outbreak. Do we have clinical contingency plans? Are we there ready to influence bodies such as NICE or other national bodies making guidelines? Do we have our top troops ready to go to the negotiating table and advocate on behalf of our population? And as I mentioned already, do we have those clinical trial groups? Not the detail of it, of course, but the structures in place ready to respond so that actually we can do work that's going to make a bigger impact than arguably some of the interventions we've seen studied so far. And behind all of this, as I touched upon at the beginning, I think there's a big question about where geriatric medicine stands as a speciality. It's historically been something of a Cinderella speciality. It's been hard work to get it to where it is. I think we're relatively well provided for in the UK from a clinical service perspective, but we're nowhere near matching supply and demand. And that may be part of the issue, is that we need to look more carefully about population need and whether the services that systems offer and healthcare services offer are fit for purpose. because despite all the experience of working with the Acute Frailty Network, trying to quality improve the National Health Service here, we still have poor outcomes, and we recently published some very distressing work showing the very poor patient experience in emergency departments. So there's only so far you can go with education, training, and quality improvement. I suspect what we need is structural reconfiguration, trying to align supply to demand. I think that's me. Hopefully I didn't take too long. I'll stop sharing. Thank you.
Thank you very much, Simon. And this is a reminder to our participants that to use the questions and answers function. If you have a question or you want to discuss about these issues, please feel free to write it in the questions and answers. So now our second speaker is Professor Kuchel, and I will just open the presentation for him.
Yeah, so thank you. It was a wonderful presentation by Simon to precede this, and thank you for the introduction, Gustavo, and also thank you for running the slides for me. I'm traveling, I'm not sure what happened. So my talk is going to focus more about what is it about frailty that enhances the risk of severe infection, hospitalization, and death. And then Sean is going to talk more about the role of vaccination and long-term sequelae. Next slide, please. So please keep looking. Most COVID-19 deaths occur in older adults, as everybody knows. And this is some data that came out early in the epidemic. Please click, showing that age was, this is CDC data, that age, if you look at a comparison group, 18 to 29 years old, click again, please, that mortality is 90-fold higher, individuals 65 to 74, and click again, please, 630-fold higher in individuals 85 years and above. And that has not changed really much in the course of the pandemic. Next slide, please. Now, chronological age or date of birth is really not the whole story. Click again, please. And there'll be many examples. Click again, and then again, of older adults. This is early on in the pandemic, of centenarians in this case, actually Italy, UK, and the US who beat COVID and have actually done quite well. So its chronological age is not the only predictor. Next slide, please. And this was actually one of the first studies that came out that we published in JAGS by Aliberti and his colleagues from Brazil, who showed very nicely that this is a CFS scale, was highly predictive of survival among hospitalized individuals in Brazil. Click again, please. And again, survival probability shown here as well. That's stratified quite nicely according to baseline frailty. Next slide, please. And so click again, please. As I warned you, Gustavo, you're going to quite a workout for your finger here. So
no problem.
No problem. Next, click again, please. So again, just keep clicking. So highest risk populations for COVID-19 include older adults with chronic diseases. Really, the multimorbidity is a problem, and some of the diseases are listed here. Older men are at greater risk than older women. Click again, please. Obesity, poverty are risk factors. There's some questions about whether race represents an additional risk factor. And again, chronological age, the number of times that the Earth has turned around the sun, click again, please, is not the best predictor. Click again, please. However, frailty, chronic diseases, physiology, social factors, and underlying biology all add essential clinical information as highlighted in this slide here with this tremendous heterogeneity of aging that we see. Click again, please. So I want to just highlight a very important issue is that folks who work in the immunology and vaccine field tend to focus very much on sterilizing immunity. But as we've learned many years ago while doing a lot of work with John McElhaney and Laura Haynes and many others in terms of studying vaccines in older adults, particularly influenza vaccine, sterilizing immunity is only part of the story. So click again, please. So as you can see here, sterilizing immunity, as illustrated on the left, is really the ability to prevent infection from taking place in the first place. And as you can see, if you do that, basically the number of people infected just goes down significantly. Click again, please. And what that does is really focusing on the role of antibodies on blocking the infection in the first place. The problem is that antibodies play a much more complex role in host immunity, coordinating the entire immune system. Click again, please. And this is a slide that we published with Jan McElhenney a number of years ago, highlighting the fact that if you look, this is in the focus in the context of influenza vaccination, but as you'll see, it applies equally well to infections such as SARS-CoV-2, that what happens is that aging, the left side represents what we see in younger people or with vaccination, the benefits of vaccination. The right side of the figure have to do with what we see with aging. And with aging, there are some dramatic declines in the ability of T cells to host cell-based immunity to be able to clear the infection once it takes place. So much more important than sterilizing immunity infection in older adults is the ability to clear the infection from different tissues, both the extent and the speed that it can be cleared with is a far more important correlate of outcomes in older adults. And as this figure shows, what happens with aging is that there is an upregulation of the Th2 side of the system, an upregulation of number of the anti-inflammatory cytokines, where some of the key pro-inflammatory cytokines, such as interferon gamma, which is a key player in this whole story in terms of being able to recruit cells and being able to clear infection through cytolytic lymphocytes, they decline. And interferon gamma has been shown to be critically important in the setting of COVID-19 infection with aging. Next slide, please. So again, this is a very nice slide published by Ladora Thompson, Holly Brown-Borg, and their colleagues, showing that the central role of chronic inflammation, which was also shown by our colleagues from Hopkins, is playing a central role in the underlying biology and drivers of frailty. Next slide, please. However, it's much more. We're now learning from a number of studies, particularly studies that are able to look at immune aging in single cells, which is really the critical way of doing that because blood is so heterogeneous, so complex, is that it's much more than inflammation that occurs with aging that predisposes to infections such as COVID-19. So you do see an expansion in monocytes, which is what reflective of this underlying increase in innate immunity with inflammation. Click again, please. But what you also see is declines in naive T cells. Next, please. Expansion and return of memory T cells, memory T cell clonotypes, and restriction of the repertoire of CD8 T cells and the ability to meet different infections. Now, there's some recent evidence, next, click again, please, showing that with frailty, with a recent single cell paper published, that TCR restriction also occurs specifically in frailty in CD4 T cells, in addition to CD8s that we see with aging. There's an expansion of CMV-specific CD8 T cell clones. Click again, please. And specific transcription factors are overexpressed in many cells. Click again. And a number of chemokines overexpressed in natural killer cells and myeloid cells. And some evidence from this one paper that novel monocyte subsets unique to frailty are expressed. Click again, please. There are some important caveats. Click again, please. This is based on one single cell RNA-seq frailty paper just published in Nature Aging earlier this year. Click again, please. And as you'll see in a moment, a total of only 5 frail subjects were studied, and that has to do with how expensive these studies are. We do a lot of these studies, and it costs approximately up to $3,000 per subject to do these kinds of analyses for each time point. Next slide, please. And so this is the paper that I'm referring to. Click again, please. And as you can see on the left, there are some changes. On the left, you can see these are changes in cord blood. It's obviously all cross-sectional to young individuals, to old individuals, and frail. And you can see that some of the changes represent, with frailty, represent simply quantitative increases of what we already see with aging, which is how we've always viewed frailty. But some actually also represent qualitative differences, which is quite unique. Next slide, please. And as I said, the caveat here is that while very well done and highly sophisticated technology, the entire study was done based on only 6 older subjects and 5 younger individuals. Plus, as shown quickly here, in addition to being frail, they had different degrees of depression, cognitive decline, and multiple morbidity, et cetera. So it's quite a heterogeneous population. Next slide, please. And I also want to address the issue of the sex differences in terms of baseline immune changes with aging. Next slide, please. This is a paper that my colleagues at Jackson Lab for Genomic Medicine and I published almost 2 years ago now, showing that basically if you do immunogenomic signatures of blood from older adults, this was almost 100 individuals of different ages that we studied. You can see a TAC-seq, which is a technology that looks at regions of chromatin that are open and ready and poised and ready to transcribe RNA. RNA-seq is actually sequencing of RNA, and you can see in blue that the cell types that are involved in inflammation are actually male biased individuals after 65, and those in turn that are involved in cell-mediated immunity, such as T cells, and those that are involved in humoral immunity, such as B cells, are actually female biased after the age of 65. Next slide, please. And this actually is kind of a summary of our data to illustrate, again, it's a cross-sectional study that with age, men have a much greater degree of inflammatory changes of all kinds as opposed to women, but in turn, the part of the immune system that defends against infection, both the B cells and T cells, are declined more in men versus women. Next slide, please. And this is a nice figure published by Sarah Haag and her colleagues, showing in the far right that as I think everybody's aware of, that there are important sex differences with frailty. With women, the curve in red showing higher rates of frailty with aging in women. However, the clinical impact appears to be more significant in men. So there's a kind of a dichotomy there, which is very interesting, with a greater impact in terms of health span and mortality in men, in spite of the fact that women tend to be more frail with aging. And I think our data may be part of the reason of that. Next slide, please. And also, I want to just briefly mention the microbiome, which is we're now discovering is a very important part of everything that's been quite neglected. Click again, please. And this is a study that's in press. It's going to be coming out in Nature Aging later this month, published by together with Julie Robison from the Center on Aging and Julia O, a colleague at the Jackson Laboratory for Genomic Medicine. And we studied a cohort of older adults living in 3 different nursing homes, long-term care facilities. We compared them to community-dwelling older adults. And what we did differently in this study from most microbiome studies is that we evaluated the microbiome across multiple different sites, both skin, mouth, and gut. Also, we did metagenomic sequencing, unlike the much more limited 16S RNA sequencing that people typically do. So we're able to sequence everything, including viruses and fungi. And also, we carefully evaluated frailty according to the Fried and Rockwood, and carefully evaluated diet, oral hygiene, and other factors. Click on next slide, please. And what we showed is that most body sites show substantial differences in microbiota composition between old and young. Click again. Over time, we showed composition over time, hyperdiversification, as well as geographic determinism, which is a specificity for each body site, declined with aging. But this kind of, what we're terming dysbiosis, is known to be associated with increased susceptibility to disease. Click again, please. And surprisingly, we didn't expect this, it was most prominent in the skin, where associations were found with frailty, which were much stronger than those found with chronological age or any other factor that we looked at. Click again, please. And so we've termed this, we're calling this now the frailty-associated dysbiosis of the skin syndrome. We'll see if it catches on. Click again, please. And also a striking depletion of Cutibacterium acnes, which is a keystone skin microbiome associated with healthy skin flora. Click again, please. And also increased prevalence of clinically relevant pathobionts, including commensal microbiomes with pathogenic potential, increased abundance of antibiotic-resistant genes. Click again, please. And we believe so that the role of these frailty-associated changes in the local microbial milieu may drive some of the increased vulnerability that we see. And we're hoping to be able to show these same kind of changes in the bronchial airway microbiome, for example, as well. Next slide, please. And so we really, in terms of immune responses, we need to think about them not as what a static changes, but what's particularly relevant to understanding aging is looking at how all of these immune responses are regulated. And it's like an orchestra. And what you see in the first slide is what typically occurs with normal infections, with T cells and antibodies being turned on and brought into the picture over time with adaptive immunity. In the middle bar, you see the typical average SARS infection, where there tends to be a far greater, with increasing viral load, there appears to be a much greater turning up of the system. And then with severe SARS-2 infection, what we see is we actually see the system being completely overwhelmed with this hyperinflammatory state towards the end. And it's kind of like the orchestra kind of starts playing on it. Everybody starts playing on their own and completely dysregulated. Next slide, please. And so I just want to end up with a few words about the role of geroscience. Time doesn't permit me to really get into this, but this is an area that we're very active and very interested in. Click again, please. And this is the idea, as shown here, that by using agents that can overcome age-related declines in the immune system, this is one example showing metformin. These are studies conducted by Jenna Bartley in our group. The idea being that you can improve influenza vaccine responses by doing that. It's already been shown for rapamycin, another geroscience-guided treatment. Over time, you can improve outcomes. Click again, please. And I just also want to mention quickly that there is actually a large study that came out by Carolyn Baramonte and her colleagues from University of Minnesota, published in New England Journal of Medicine. While the study did not meet its primary endpoints, which is an aggregate of disease severity, the use of metformin actually, as a secondary outcome, delayed ED visits and hospitalizations significantly, and that certainly needs to be pursued. I also finally want to say just very quickly, and there's not enough time to talk about this, but there's a lot of evidence now that cellular senescence plays a major role in enhanced vulnerability to many infections, including coronavirus and SARS-CoV-2 in particular. And there are ongoing trials, some led by Jim Kirkland's group at Mayo Clinic, some of which we're involved in, testing senolytics, both in the context of frailty, as well as in the context of a SARS-CoV-2 infection, including in nursing homes. Next slide, please. So I'll end here just very quickly. Sorry to just rush through all of this. In conclusion, frailty represents an important and potentially modifiable risk factor of severe COVID-19 infection, hospitalization, and death following SARS-CoV-2 infection. Immune changes contribute to such vulnerability more in men than women. There is positive feedback loops and system decompensation that play a role in this. I didn't have time to get into that. There is something that's dysregulation involved in immune system, as well as what we're referring to as dysbiosis of the skin involving the microbiome that we believe are relevant to this. Click again, please. And there's a role of biological aging. And then finally, there's definitely a role for geroscience-guided therapies that are currently under study. So I want to thank you for your attention. I want to thank my projectionist for an excellent job.
Thank you very much, George. That was fantastic. As I mentioned, this is a translational seminar. So we started with a very elegant presentation on the social and population characteristics of this association between frailty and COVID. And now George has given us a very nice presentation on the biological characteristics and biological behavior. And now we are moving into the third component, which will be more therapeutic by Sean. So Sean, all yours.
Okay, good. Well, I'd like to thank Gustavo and the organizing committee for for inviting me to join the panel to speak. And also, I'd like to thank George and Simon. Give wonderful presentation. So your talks make my job easier. So what I would like to do is just continue the discussion. I would like to, as George mentioned, aging is a significant risk of for severe disease, COVID-19 disease. And what I would like to mention here, really the pandemic is not over. So as Simon mentioned, we're probably aging, and even COVID itself, because this thing has been going on for over 2.5 years, kind of faded in the background. And here I wanted to remind everyone that's not the case. So here, Johns Hopkins has this real-time tracing, worldwide tracing map. As shown here, I just got this snapshot earlier this morning. So it really has, a lot of different information on this website. And for those of you who are interested, I would strongly, really suggest you. But I would just touch upon, really a few points here. Here, when you look at, it shows the overall, the total cases, for example, over 600 million cases worldwide, and then total deaths is over 6.5 million, and then it's really nice to see how many doses of actually vaccine that have been given, over 9 trillion doses. But the reason I want to emphasize that point is the pandemic is not over. Is you also look at the last 28 days. So we're still over really globally almost 13 million cases for the past 28 days. And then when you look at the deaths, it's over 40,000. And here is actually on the left, you can show the numbers each in different countries. In the US, for the past 4 weeks, is over 1.3 million. And then the death is, over 11,000. And, we recognize actually, in West Europe, I don't show the UK data here, it's far down, but in Germany, it's actually higher, in terms of cases than what's reported, here in the US. And I also want to emphasize, particularly the cases documented here is probably it's underestimated, vastly underestimated, particularly in the US, because we have now home test kits, and many people may not, really report that. And then also perhaps mortality, deaths number is also underestimated. So then when you look at the age, the vulnerability related aging. So here is the most recent report by Vox. And you can see the death rate, the daily death rate in the US during the summer. This is up to the end of August. I mean, really, this every day in the U.S. you got really about 300 to 400 deaths every day. And then when you look at, well, what are the people die? It still die from COVID-19. Is if you look at those people unvaccinated, whether you're young or old, actually, you got like for example, 6 to 11 times higher, risk to die. But then when you look at the aging population, so those people like 53% of this deaths occurred in those who are 80 years and older. And then in addition to that, 27% occurred between 65 to 79. So altogether, if you talk about older adults, 65 years and older, that actually still account to 80% of deaths. Now there are many different reasons. George actually laid out very nicely, in terms of immunosenescence. So here's the paper our group published, very early on, to really speculating at that time, particularly why, the vulnerability for older individuals, particularly those who are frail. And we want to go into this in a great detail, but it's really mentioned about inflammation that George touched upon, and of course, the immunosenescence. And altogether is really the vulnerability to the severe COVID-19 disease and death. And then, when you look at the, actually immune response to vaccination, as the pandemic goes on, it really continues, it gets more complicated. So because, people, got infected and also got vaccinated, what we call the hyperimmunity, But those got vaccinated and then also waning, and we have some data to show you. So I'm going to spend most of the time to talk about the study we have just published. And so here is a study built on our ongoing cohort of actually influenza immunization study. We target those individuals who live in the community who are 75 years and older. When the mRNA-based vaccine, COVID vaccine, became available here in the U.S., we started to, having those people join, started this new study. So what shows here on the left, this data just published by the Clinical Infectious Disease, just a few weeks ago. So we, what we did is we follow them up, and because those individuals, mostly in their 80s and 90s, they were already in our influenza immunization study. So we did have a pre-vaccination sample from all of them. It's about 86 people. And then we were able to get I don't know whether I could get this thing. Just give me a second. So I won't be able to get the highlight here, am I? Okay, well, let's just show you here. So when you look at the figure on the left, we looked at the antibodies at 4 different actually parameters. The panel A and B on the left is looking at the total COVID, SARS-CoV-2. The A is the the total S protein, and the B is the total IgG antibody titer against the receptor binding domain of the S protein. And the panel C and D are the functional aspect of those antibodies. One is the ACE inhibition, ACE2 inhibition, but then the bottom one, D, it shows the active neutralizing antibody. And so you can see the different time points. From the further left is the baseline, that's pre-vaccination sample, right? So, and then we did many of them. We got 25 people, we were able to get a sample between the first 2 doses. And then the third time point here is the 1 month after the second dose. So that's the the initial 2-dose series, right? And then we follow them up. And then the time point after the second dose is we 3 months after the second dose, and then also the 6 months after the second dose. And then we also got a blood sample after the booster dose, actually the first booster dose. And the study is still ongoing as they get the second booster dose. Now some of them get the third booster dose. We now numbered as like dose 1, 2, 3, 4, 5. But anyway, what you can see is really when you look at the antibody titer, particularly the functional aspect, the ACE2 inhibition as well as the neutralizing antibody, really the immunity waning is very evident. When you look at the functional, almost after 6 months, and really fast and down to almost baseline. So that's what George said. Really the dynamic immune response. This really shows up here, and I would further emphasize really, at least in the U.S., the CDC guideline, recommendation, for boosting the immunity, for this vulnerable older adult population is critical. And then the panel, kind of complicated panel on the right, is really emphasize basically 2 aspects. And George already mentioned about the sex difference. So you can see the first 2 panel here. I can't get this to work for some reason. Anyway, so the first 2 panel here is looking basically, the sex difference. So you can see overall when you look at all those time points, and the pink, well, first one, A, B, C, D is the age difference. So we further stratify the age from 75 to 82, 83 to 87, and then 88 years plus. So you can clearly see the older individuals, even in this old subset, the antibody titer is pretty much lower in all time points we checked. And then the second one is look at the male and female. This is at the peak of the antibody response. And then the third one is really look at the frailty. So which is really most pertinent here is you can see the yellow line is the frail one. You can clearly see, particularly when you look at the functional measure, the neutralizing antibody as well as the H2 inhibition. It's really by all time points it's lower. Even at the response to the booster dose. So here emphasize really the impact of frailty on the antibody response. And then I was asked to also talk about, well, what about COVID-19, the impact of actually disability and other measures. So here I kind of show you the data from UK in terms of long COVID. So what's up here is really a monthly at the top is the monthly data actually shows the daily cases of long COVID. And then, the 2 points I wanted to make here, number one, it is high, per 10,000 individuals, but also people may think now, with the Omicron variant, people may think that the disease is minor, but then when you look at the impact, really the long COVID seems to really getting up because it's, it's really not, think many people may think about, well, now becomes a, like a regular flu, but that's not the case. This is data up to the end of March. And I think they continue actually to collect the data as well. Now, when you look, how do you define the long COVID symptoms? And it's mostly, basically, the disability, in older individuals, tiredness, weakness, and then also shortness of breath. Those are two most common ones. But also the, difficulty concentrating. Some people may call it, a brain fog, and that's actually, really the cognitive, cognitive disability. So to me, I wanted to take this opportunity to emphasize, really the COVID-19 pandemic is not over yet. We still need to be, really vigilant, but also consider the frailty, how that, older individuals and how we're going to move forward to handle this. And the last 1 minute also, I'd like to, talk about our Johns Hopkins Center on Aging and Immune Remodeling. So, SARS-CoV-2 vaccination is one of our studies. And as George mentioned, we actually look into the longitudinal immune remodeling and to see how would that actually impact what we care, about our older patients. I'd like to stop here. Thank you very much.
Thank you very much, Sean. I will just wait for you to stop sharing your screen.
Yes, let me see. Okay, here we go.
Thank you. So I invite our three speakers to open your microphones, and we are going to have some questions and answers session. And if you want to establish a conversation and interaction amongst yourselves regarding what was presented so far. So I will start with a very interesting question about any clear or specific contingency plans. What about countries that in which frailty is not well identified? Countries like developing countries. What would be your advice in that kind of setting? Who wants to start?
I can only see you at the moment, so I don't know if anybody else has got their hand up. Maybe it's my screen display. But I'm happy to have a go.
Yeah.
Yeah. So you have to start somewhere with all of these things. So I don't think it matters whether you've, your country is already grading or assessing frailty. Frailty is important for sure. It helps unpick the heterogeneity of the aging population, as we've heard, both in the context of COVID and a wide range of other conditions. So it's an important concept, but inevitably different countries across the world are going to be at different starting points in terms of where they want to take things. And I think the key to this is a network. And it could be that this is the platform, or there are other platforms, but we have to work together. And I think what we saw in some scientific communities was really fantastic international collaboration. And I'm not saying there wasn't any of that within the world of frailty and geriatrics, but I think that we could do better. And by working together and helping, COVID's a classic example, isn't it? It's a global pandemic. So there's no point having fantastic, wonderful services in one country if we're leaving the rest behind. So it's only by working together and supporting each other that we can make a difference. So don't worry about where you're starting from, but I think let's get connected and support each other.
Thank you. Any other comments from the panel?
But I think it's not only a disease of underdeveloped countries. I mean, in terms of the challenges, I mean, in the United States, including parts of the country which are rich, like Connecticut, where I work, the problems also lie with the workforce, which is underpaid and has really borne the brunt of the challenges, particularly in long-term care setting. And so many of the challenges, particularly early on in the pandemic, we realized had to do with the workforce and the fact that, for example, we discovered that many of our staff, because they're underpaid, actually held more than one job. They worked in more than one facility. And early on, before we had vaccines, they actually became the unwilling vectors for transmission. So these are complex issues in both well-to-do and developing countries.
Yes, I would like to echo that. I mean, it's not only, I think I would not too much emphasize the really semantics of frailty. It's really how do we take care of those most vulnerable older patients. And for example, in Hopkins, really the folks in the infectious disease division, they developed this risk scale. And, they did not really include the frailty word in there. But what you look into that is really the age, and then further stratify those who have multiple comorbid comorbid diseases, and all those risk factors, whether you're vaccinated or not vaccinated. And those really, we should work, in that route as well. Rather than too much in terms of worry about, the semantics.
Thank you. Everybody's reminded to please submit your questions through the questions and answers. We still have plenty of time to answer some of your questions or share your experiences. I have a question here regarding the interventions to prepare the frail older population against the next wave. Sometimes our preparation is focused, particularly in influenza, is focused on vaccination. So they get the vaccine, they sit down and wait for the wave to pass by. What interventions other than vaccinations do you think will be effective to prepare our frail older persons to the next wave, if there is any, or to the endemic occurrence of COVID? Who wants to?
Well, I can start. Well, yeah. First of all, actually, I would certainly emphasize, the booster vaccination. So, just based on our data, and now, at least in the U.S., we have a bivalent, vaccine, which does include, the Omicron, variant. And then I'd like to point out also, in addition to the mRNA-based vaccine, some other, in the industry, for example, Sanofi, they partner with GSK to develop the, adjuvanted vaccine. That can be potentially, a good booster vaccine as well. Now, in addition to the vaccination, there obviously a number of different other measures we can take. I mean, obviously at the beginning of the pandemic, we emphasized the quarantine measures, right? But now, as the pandemic continues, it's probably not feasible for the overall public. But if you look at the long-term care facilities, and those quarantine measures, still matter. In addition to that, there are some other ways in terms of the monoclonal antibody therapies and the preventative, for example, convalescent plasma. I mean, I'm not recommending to give everyone older, frail individuals of those measures. But then if you really under very, under specific circumstances, and that may be considered as well. And then also in terms of antiviral treatment, I mean, the Paxlovid, it's quite, quite safe and also effective, in treatment there as well.
Thank you. Any comments from George or Simon?
I agree with that. Just to add to it that with all of this, we can't forget about public hygiene measures, and it's certainly as important here as anywhere else. I think the benefits of exercise and good nutrition are important. There's evidence to support that. And in terms of these none of these off-label drugs have really panned out so far. I think the only exception is metformin, which I showed the data. I think that the New England Journal of Medicine interpretation of the data was a little too Catholic for my liking, where they only went with the primary outcome as a credible. I think the secondary outcome in terms of metformin of the 3 drugs, I think the data was very credible, statistically significant, clinically meaningful in terms of ED visits and hospital visits and death. Now I realize it was a secondary outcome, but it was preconceived, it was pre-designed secondary outcome. So I think there may be some role in there. I'm not suggesting putting people who are not diabetic on metformin, but if you have a late onset diabetic already an oral hypoglycemic, there are real advantages to switching them to metformin because it has effects on biological aging, which no other oral hypoglycemic has. So.
Thank you. Simon, any other comments regarding?
Yeah, I mean, aside from pharmacotherapy and vaccines, I think exercise is so critical, but just let's, broaden it again, the wider determinants of health, connections, avoiding isolation, socioeconomic deprivation. I appreciate not all of these are modifiable within our gift, but, the drugs aside, there is so many other things, diet, nutrition, already been touched upon, that people can be doing. The answer to surviving COVID well, to some extent, is the answer to living healthily more generically. So we shouldn't forget those aspects.
And don't forget influenza vaccine. I think that there's a real concern about influenza this year. For multiple reasons. It could be a big year.
Right. Thank you. So we have a question from Elisa Andrew. How can we work towards getting frail participants and frailty measures included in vaccine trials?
Yep.
Will it be enough to encourage bottom-up or voluntary inclusion, or will regulators need to demand it? Any comments? Simon, you were going to?
Well, yeah, I mean, this is such a good point. I can speak from the UK perspective. We have spectacularly failed to reflect older people's, what matters to older people in terms of outcome measures in the vast majority of trials, and certainly in the COVID-related trials. It's all been about avoiding death, which of course is important, I'm not neglecting that, and avoiding hospitalization and resource use. There's nothing about what matters or person-centered outcomes. And I think the answer is a combination of both, Melissa. First, we need to get the scientific community thinking about a range of outcome measures that matter to older people that should be, the consensus process. We've just been through one in the UK that's kind of convened a core outcomes, a core set of outcomes that should be included in frailty trials. But unless we engage with the regulatory authorities and get them to support or maybe mandate inclusion of some of those measures, I don't think it will have the desired effect. So, well, from the bottom up and top down. And we need to get people in positions of influence, so the scientific leaders in gerontology need to be there at the table to influence the discussions.
Thank you. Any other comments, Sean or George?
Yeah, I would echo that. It's really, to me, frailty, not only, consider its major impact on the immune response to vaccination, for example, but also how this, as George, laid out in his presentation, how that actually dynamically influence durability of the immunity. And what our data showed, really, frail individuals really wane, the immunity waning is really a big issue. And now whether, I think first of all, we need to get the, as Simon's mentioned, our scientific community to have this concept, to be integrated into any research studies, we design. And then also, I think really from the RFAs, I'm reading from NIH, they started to pay attention, obviously the recognition has significantly increased, that's a good thing. But then the issue is when you get to the local, really individual institutions, then every one of us need to do perhaps a better job, how to convince our IRBs or our other, research office, individuals, and then also the whole team, how to, whether it should be mandated or not, I think, for if anything is started, in aging research, I think we should.
Thank you, Sean. Any final short comment, George?
Just quickly, that I think it's a clinical issue, it's a recruitment issue, and it's a political issue. And in terms of politics, for those of us who work with National Institute of Health in the U.S., it took us years to develop a policy where now it's been around for about 5 years, where if you put a grant to NIH, you have to justify why you did not include older adults in your study. But that's just the phase. That's the first phase. What we're working on now is to convince NIH to justify why you didn't include older adults who resemble the patients that we see in our clinical practice. So frail older adults with multiple morbidity, all the patients that clinical trialists want to run away from. But it's absolutely vital that that be done. And so it's a combination of challenges.
Okay, thank you very much. I think that we're running over time, and this exactly when a lot of questions are coming in. So unfortunately, we will not have time to answer all the questions that have been submitted to the panel. I would like to thank our 3 speakers. I think we all agree that it was a set of very excellent illustrative lectures from a very translational perspective. So thank you very much, Simon, George, and Sean for your presentations and for participating in this panel.
Thank you.
Just a reminder that our next seminar is on November 9th. Our speaker will be Dr. Roger Fielding from Tufts University, and he will be talking about sarcopenia, frailty, and geroscience. So it will be a nice continuation of the concept of geroscience within the frailty field. So with this, I would like to just on behalf of the Global Frailty Network, thank everyone for your attendance. You are more than welcome to join our Frailty Network from all over the world. You will receive a survey at the end of this session, and please express your interest. We will include you in our mailing list and also in participating in all our future activities. Our website is under construction, so we will have some more information available online soon. With this, I would like to thank you, everyone, for attending this session, and wishing you a nice rest of the day or evening or wherever you are in the world at this moment. Bye-bye.